When prostate cancer is found, prostate cancer needs to be evaluated properly. It used to be back in the day that when prostate cancer was found, if it was found on a Friday, we'd be operating on you on the following Wednesday. We don't do that anymore, and we don't do that in regard to any Gleason score that an individual would have. Most of you know what Gleason grades are, and most of you know what Gleason scores are. But a Gleason grade is graded 1 to 5, and the most dominant cancer, 1 to 5, is noted, and then the second most common grade of cancer is evaluated for, and that's given a number. The most common cancer found, 50 to 60% of the time, is a Gleason 6 cancer. 30% of the time it's a Gleason 7, and 13% of the time it's 8s, 9s, and 10s. 8s, 9s, and 10s are extremely aggressive. 7s are equally aggressive, but not quite as aggressive as the 8s, 9s, and 10s. 6s are cancers that people tend to live with. Actually, it's been noted by Michael Berry and others at Harvard that 30 to 56% of all cases of prostate cancer are actually overdiagnosed. The reason they're overdiagnosed is because doctors take men who can live with a 6 and they're trying to treat them. This is another reason for MRI. If you have an MRI done with a 3 Tesla magnet, we can now tell you where your cancer is located. We don't want to know, as an example, until after your MRI has been done, a record has been made about what is seen on the MRI. At that point, we'll now take a look at your biopsy report and see whether or not there's the correlation that we expect to see. And oftentimes, we're able, and frankly, in all times, we're able to identify the cancers. And when I say in all instances, we've gotten very good at this with having done thousands of cases that we've seen over the years. So we know what we're doing. The issue with MRI mostly is that many doctors on the radiology side do not have the experience. So they tend not to read the same way as somebody would read from the NIH, as an example, or some of these pockets of doctors, such as we have in Sarasota, as an example, Sarasota, Florida. So these doctors are well schooled on the topic. They don't need any help. They can evaluate the images, and actually over the years I've gotten to be very good at this as well. And I also like to lend a hand, take a look at the images independent of the radiologist, and make my own assessment. So I was talking to you about Gleason 6s as being cancers that are overtreated 30 to 56% of the time, again based on Michael Berry's work. So these individuals need to have an MRI done to allow you to know whether or not it makes sense to live with the disease, or should you do something about it. Well, we know because of where the cancer is located, if it's next to the capsule, as an example, we may not want to sit on that cancer. If it's at the apex, as an example, we may not want to sit on that cancer. The apex would be furthest away from the bladder, and it would be just in back of the sphincter. We also don't want to be sitting on cancers that are anterior, up high, versus the rectal wall. Those are cancers that get into the fibromuscular stroma. Those are cancers that can be aggressive, and those are cancers that are oftentimes not found on anyone's biopsy. So you need to have the MRI to know what's going on. I recently had a patient that was referred to me from North Carolina, and this person was actually referred from another banker that had seen me prior. And the individual, when he came to see me, came with his biopsy in hand. And typical for my practice, I don't want to see the biopsy. We're going to do the scan, and then once we've done the scan, we'll see what we see. Well, as it turns out, this individual had 2 cancers, but only 1 cancer was noted on the biopsy. The number 1 cancer, or what we call the index lesion, or the most dominant cancer found in this individual, was actually anterior. So this is a cancer that no one would have noted or diagnosed with a typical biopsy needle stick. It would be very difficult to hit that area unless you knew exactly where to go with your needle. and typically doctors don't do that because it's painful. We can tear the colon wall trying to get there. So there's a lot of reasons why we don't do that. But nevertheless, this individual went from a case where we were going to live with the disease with his Gleason 6 to where he cannot live with the disease because of the cancer we found anteriorly, which is more aggressive than the cancer that was identified. So oftentimes the biopsy just gives us a glimmer of what's really going on. Unless you image, you can't really tell what is going on in the prostate. So I encourage everyone out there that's watching this is to pay attention to MRI. Get your MRI. Don't hesitate to do that. I'm here to help you, and give us a call. Talk to me about your case, but with an understanding of what's going on, we'll be able to tell you whether it makes sense to live with your disease as your doctor suggests, or better stated, as you'd prefer to do. And we have a farm team where lots of patients live with prostate cancer, so we're going to encourage you to do that. For those individuals that can't live with their disease, and I'm often asked, what would I do? What's my next step? What's my treatment of choice? My treatment of choice is based on my ability to have done many radicals in my career, and also I've done many cryos in my career, cryosurgery where we freeze the prostate. A radical is obviously taking out the prostate by any means, a robot or traditionally just unzipping you, if you will, from above your navel down to your pubic bone and taking out the prostate in what we call a retropubic approach. So regardless of the approach that we use and how we take out the prostate, a radical is a radical is a radical. Beyond that, we have radiation. Very few people are sent to radiation by me because of information by Ralph DeVere White. We talk about that on our webinar, which is on the MRIS site, a 90-minute PowerPoint presentation. In that particular webinar, you're going to learn that 40 to 60% of men fail to be cured by 7 to 10 years. We're going to validate the references for you so you can see firsthand why it is that you need to pay attention to the disease that you have. So what I've done, I'm into my 8th year now of treating with a procedure called high-intensity focused ultrasound. Now, if you look at me and I look at you and you ask me, what really sets you apart from the rest of the world? What I can tell you is that what sets me apart from the rest of the world is I've discovered or realized that imaging is the key to the success of any treatment. If you haven't been adequately imaged, we are going to fail because we have no way of knowing the extent of the disease that you have without imaging. So therefore, imaging is absolutely a necessity for anyone that's watching this video. You must get that image so we know what's going on. Swinging back to high-intensity focused ultrasound, I am uniquely positioned in the world, having treated more than 100 patients with the 2 technologies that are available. I started out with the Sonoblade 500, which is a company out of Charlotte. I have since migrated to a company out of France. The EDAB machine is called Ablatherm, A-B-L-A-T-H-E-R-M. The Ablatherm model is a robotic model. So because it's robotic, it has safety features built in that add advantage to the patient from a safety point of view. From my point of view, treating with HIFU, I do like to compete with the rest of the world. I want to be as good as the rest of the world for sure, but I certainly want to see how my data stacks up with the rest of the world. I don't care what treatment that you have that's performed. Every procedure that you would consider is associated with the potential for impotency, incontinence, bowel injury, inability to get all the cancer, and urethral stricture or urethral narrowing. And it's similar to taking a drink out of a straw and somebody squeezing the straw. So the scar tissue takes place in about 20 to 25% of patients. So it's an issue that we can deal with locally through any local urologist as an example. It's just not a big deal. So in the bigger picture, the fact that we don't have issues with impotency, incontinence, bowel injury, or inability to get all the cancer, I would suggest that I could possibly be your HIFU treating physician. We have competition in the field for sure, so what we've done is we've taken a look at our data and we've actually compared our data to that out of Canada. As we look at those two, we actually put out a press release, so some of you may find that on our site. But specifically what we've done is we've looked to see how well we've done specifically in our biopsy segment of those individuals that we treated. And what we found is in 70 patients that were pretty much split between Gleason 6 and Gleason 7, and now we're into our 7th year. None of these patients have impotency, none of them have bowel injury, none of them have incontinence, and we're able to get the cancer in every single instance. If there's one key factor for your success through me, and that is what we call the sweet spot study, or the sweet spot of the data that we're looking at. To qualify for that, your PSA must be 8.5 or lower. If it's over 8.5, we can still cure you of your cancer to the tune of about 95%. We miss on about 5 patients per 100, but we're asked to treat men with PSAs of 14, 18, 20, 22. Many of those patients have great success with the HIFU procedure. But if you're looking for outstanding success, we suggest that if you're living with a 6, go back and reconsider what the progression is of your PSA. Do not allow your PSA to go above 7, because if it goes above 7, 8.5 can't be far behind. So if you're treated with a PSA of 8.5 or under, and a Gleason score of 6, 7, 8, 9, or 10, I don't care what the Gleason score, we're going to cure your cancer with HIFU to the tune of 99%. By comparing our data to that out of Canada, their data was published on 402 patients in the British Journal of Urology in 2012. And this was data out of the Cleveland Clinic. What they showed in their 402 patients, looking at Gleason 6s and Gleason 7s, that they basically missed on 1 out of every 4 Gleason 6s that they treated. So that means only 3 out of 4 Gleason 6s succeeded with HIFU under their watch. If we looked at their Gleason 7s, we found that this is more aggressive disease for sure, so we would not expect them to perform as well based on how they're doing with Gleason 6s. True to form, they're not. 1 in every 3 patients that have a Gleason 7 will fail using the Cleveland Clinic's system. And they use the same technology as I do using the Ablatherm machine or technology from France. So what I would say to you is when you're looking for a treatment, look for the doctor. And I want to point out, when you're going and considering where you're going to go for your HIFU treatment, obviously I want you to look at our level of excellence. I want you to get to know who I am as a person. I want to get to know you as a person. You're not a number when you come to see me. I'm not suggesting that when you go somewhere else, you are a number, but there's a reason for failure in those other centers. I can't put my finger on what it is, but when you come to us, we give you personalized service, and bottom line is we achieve great results and expect great results with you going forward. So again, give us a call, let us talk to you, tell us about your problem, tell us what you want to do, but again, you're not buying a car, you're choosing a physician that does a very technically oriented procedure that requires excellence in imaging, and that's what I bring to the table.